Okay, this is chapter 12 in your Rollins textbook, and the topic is pain. Research indicates that pain, by nature, assessment, and treatment for children's pain has increased exponentially over the last 2 decades. Pain remains one of the most misunderstood, underdiagnosed, and undertreated and untreated medical problem, particularly in children. Pain is very subjective to an individual, and it's difficult to accurately assess, which makes sense then that it might be undertreated in children for this simple reason that they may not be able to communicate the level of pain that they're in, and it can be confused with fear and anxiety over medical events. So what is pain? According to the International Association for the Study of Pain, pain is defined as an unpleasant sensory and emotional experience associated with actual or potential damage, or described in terms of such damage. Pain is a unique personal experience, with individuals varying widely in their perception and tolerance of pain. Pain duration can be described as acute pain, which is pain of brief duration, which goes away with treatment or healing and can be caused by injury, surgery, illness, trauma, or a painful medical procedure. Additionally, chronic pain exists beyond the expected time for healing, which is 3 to 6 months. And chronic pain can be further divided into 2 categories known as chronic malignant pain or chronic non-malignant pain. These types of pain categories are associated with leukemia, cancer, and its treatments. And chronic malignant pain is expected to end either by cure or death. Chronic non-malignant pain has no predictable ending. Pain type, which is a second method for classifying pain, is according to the type of pain that it is: somatic, visceral, bone pain, or neuropathic pain. Sources of somatic pain are skin, muscle, and connective tissue. Visceral pain is associated with internal organs. Bone pain is caused by sensitive nerve fibers in the outer surface of bone. And lastly, neuropathic pain, which comes from nerves or nerve damage. Outcomes of unrelieved pain. Individuals who experience pain is important in avoiding physical harm. Unrelieved pain, however, can be harmful both psychologically and physiologically. Perception of pain can be increased by heightened fear and anxiety. Neonates are especially at risk, according to an ad in 1998, because they experience increased sensitivity to pain compared to older children. When you think about it, they have the same number of nerve endings as an older child, but in a smaller, condensed area. The neonate brain is considered plastic or malleable, creating a vulnerability to early adverse experiences. Repeated exposure to pain may develop altered pain sensitivity, anxiety, stress disorders, hyperactivity, an attention deficit disorder, impaired social skills, and patterns of self-destructive behavior. When we assess children's pain, there are three categories of behavioral indicators that are used to assess children's pain, according to Gurek in 2005. There's a global rating scale, and we rely on assessment of predictable behavioral indicators of pain, such as crying, wincing, screaming. There are indirect measures of pain, such as requests for medication or well behavior, such as play. And then there's behavioral observation scales, which focus on documentation of specific behaviors indicative of pain. When we assess children's pain, patient self-report and behavioral observation are physiologic measures, such as heart rate and blood pressure. Assessing pain in children is challenging due to subjectivity of their response. Infants, we look at observational cues such as sweaty or pale or non-eating or sleeping well or too well or crying as indicators of distress. With toddlers, language skills provide additional cues to perceived pain. Some toddlers become quiet or inactive or very active from fear or perceived painful events. I'm sorry about the typo here. School-age children rely on describing the pain and location and are capable of great self-control, holding still, closing their eyes, looking away. Adolescents can accurately describe pain, its intensity, and location, and may exhibit a high degree of control. There are other influences on children's response to pain. A child's coping style, and there are two basic types of coping styles. Children who are categorized as attenders or monitors, who are information seeking, or distractors or blunters, who are information avoiding. Past experience with pain can be categorized as children who remember painful experiences, which can alter their response to perception of painful experiences. In other words, it's anticipated pain due to previous experiences that were painful. There are family and cultural styles, family beliefs, attitudes, parental pain history, influence of how children learn about pain, its impact, and how to cope with it. Children look to parents during a painful situation to learn how to react. If parents suggest, don't cry, don't be a baby, then children might not cry, or they might hold in their expression of a painful event. Situational factors, according to McGrath in 2005, cites three specific factors related to how children experience pain. What children and parents understand about a potentially painful experience, what they and the healthcare staff do during a potentially painful situation, and how children and parents feel. In terms of chronic pain, children with chronic pain tend to have more anxious, internalizing characteristics than externalizing problems. Biological and psychological characteristics are believed to play an interactive role in the experience and expression of pain, and are likely to contribute to gender differences in adjustment and coping responses. The ways children cope with chronic pain is believed to play an important role in health-related outcomes, such as pain intensity and functional disability. A recent study by Lynch, 2007, found girls used social support more than boys who used more behavioral distraction techniques, and adolescents engaged in more positive self-statements than younger children. In other words, rehearsing, you can do this, you've got this, you can handle this. Some special considerations. Medications are available to help children manage pain. However, they're frequently under-medicated. Some of those medications might be LMX cream or EMLA cream or cold spray, which is another name for ethyl chloride, which is sprayed on an area where a child might get a needle poke, something like that. Behavioral techniques can be used to distract children during painful procedures to alleviate fear and anxiety. Children respond to pain control strategies that improve their imagination and senses of play. In an emergency setting, children prefer music to toys. And in some situations, vibration, such as the Buzzy tool, which is either a bumblebee or ladybug tool that is used, and I don't know if you can hear this, but it provides a vibration. And it is put between the pain area and the brain. And it fools the brain to concentrate on the vibration rather than the painful sight. Hypnosis provides an altered state of consciousness. This technique is similar to relaxation and guided imagery exercises. And then lastly, biofeedback is a pain relief mechanism based on specific physiologic changes caused by the biofeedback. Some suggested interventions for managing children's pain by developmental stage. The first stage being infants, parental presence is important. Verbal reassurance, soothing, rocking, holding, a pacifier for sucking, and familiar objects. Often we dip a pacifier in a sugar solution, and there are pacifiers that have been pre-dipped in sugar solution called sweeties, and the sugar solution reacts physiologically with the infant to decrease any discomfort, that painful event. For toddlers, again, parental presence, video cartoons as a distraction, active play, other forms of distraction, bubbles, music. And each of these interventions build from one stage to the next. With preschoolers, again, parental presence, slow and rhythmic breathing, distraction, singing, stories, art, repetition, vocalizations, touch, role play. With school-age children, again, distraction, talking, music, games, art, relaxation techniques, preparation and rehearsal, reading books with similar situations. And then adolescents, verbalization, imagery, relaxation techniques, closing your eyes, going to your happy place, preparation, rehearsal, practice, distraction, reading, music, art. And then the activity for this week is a pain thermometer. It can be either different Band-Aid sizes with notations under the Band-Aid sizes that the large Band-Aid would be a lot of pain. The smallest Band-Aid, the tiny little circle Band-Aid, could indicate very little or no pain. Or you could use a thermometer or like a cylinder with different levels of pain from 1 to 10.